Hello, good afternoon. Can you hear me?
Yes, we can hear you.
Perfect.
And
So I had some problems. I heard your speech, but I had some problems to get the connection because something is wrong with the internet here. So first of all, thank you very much for inviting me. It's really a pleasure to be there again. I think I attended your meeting a couple of years ago, so I enjoyed it very much. So it's nice to be back, although it's just virtual, of course, for obvious reasons. So let me share my slides here. So you asked me initially to talk about my perspective on peripheral vascular and structural heart revolution. And I thought, oh my God, that is too much. So I asked you for a change in the title, and I asked you to put in my personal perspective on peripheral vascular and structural heart revolution, and also to add selected projects and innovations just to narrow the scope of the topic a little bit down. And then I started working on my slides, and I thought, oh my God, that is still by far too much. So I eliminated peripheral vascular disease. So the new title of my presentation will be my personal perspective on structural heart revolution. And it's just a broad topic. There is no other field in medicine where so much progress has been made as in structural interventions. We now can open everything, we can close everything, we can replace everything, we can repair everything. We are really the greatest, and sometimes the question comes up, do we need the future at all with all these achievements we already have achieved? But in fact, it is just taking off right now, and I will show you just some examples what's going on in this field. So we have 15 minutes about the future, and I will talk a little bit about improvement of existing technologies, about new technologies in this field. And for the purpose of this lecture, in order to narrow it down even more, I will focus on projects where our center is involved in one or in the other way. We will talk about shunt closure, LAA closure, valves, and heart failure treatment, which is another big field which is currently part of the structural interventions, but I think this will evolve into an own field like peripheral, coronary, structural. In the next years, we will talk about heart failure treatment interventions. We are working on bioresorbable occluders, and this is one example, the CARAC device, where we have done first in man and ASDs and PFOs. And the idea is that with this type of device, we can avoid all these long-term complications, which are rare, but which are very important, of course. And we have seen with regular ASD devices, we have seen erosions now occurring after 14 years after device implantation. And by working on these bioresorbable occluders, I think we can eliminate these long-term complications of any closure devices. And there's another approach, the LifeTech absorbable ASD closure system, which is also already first in man, and they are now starting with a bigger trial with this. And here you can see the comparison. These are nitinol occluders, and here you can see these bioresorbable occluders, and after 2 years, they are completely resorbed. And this is another concept. In this case, we are not working on a bioresorbable frame, but the cover of this device will be resorbable. So that means with this type of devices, as you can imagine, you can easily do transeptal puncture after this central part, this patch, has resorbed. Then due to the frame structure of these devices, you can easily do transeptal puncture in case other left heart procedures become necessary in this particular patient. And there is, of course, suture-based PFO closure. We now can close PFOs by a suture technology, and we are also working on ASDs and other defects, whereby catheter triggered suture devices, we can close these defects. Then sinus venosus atrial septal defects, you all know this is about 5 to 10% of all ASDs. We have the superior vena cava type, and it's more common than the inferior cava type. It's usually associated or often associated with anomalous pulmonary vein return. And the current thinking is that catheter closure of these devices is not possible. In fact, we closed the first of these devices couple of years ago with an immediate patch technique developed from Sievert in Athens in Greece. And then from Hussein Abdullah, another technique has been developed, which is, I think, really the way to go. It's basically working like stent implantation of covered stents in the superior vena cava. And by doing so, you can close the connection. And there's still, in most of these patients, as you see in this model, in most of these patients, there is still enough room around the stent graft, so that the pulmonary vein still drains into the left atrium, even if the stent is implanted. This shows you an example. Here's the covered stent in the SVC implanted. You can see an injection into the upper pulmonary vein, and you can see how it drains into the left atrium. So this is an upcoming technique for closure of sinus venosus defects. Now let's move on to left atrial appendage closure. These are the devices which are commonly used: the WATCHMAN device, the amulet, the wave crest, and the lariat, which is a technique where you go from the pericardial space and you can ligate the appendage from outside. And there's a new device, the lumbar occluder. We did first amend with this. So it's a Chinese development, a different structure, different design with hooks and barbs. So this is a device which cannot embolize and has several other advantages. We cannot go through all these details in the interest of time. And then there's, of course, the new WATCHMAN Flex, which looks a little bit like the old WATCHMAN, but it's a completely different device. When you see how this is implanted, it's very much easier to implant. It's more safe because there are no distal sharp ends of the device, and it's shorter, so it can be used in most appendages in these days, even in those where the landing zone is shorter than what we had to have with the old WATCHMAN device. But there are a huge number of other devices which are currently already in human trials or in early animal trials. I cannot go through all these. There are more than 20 different techniques which are under development. I will just mention one of these here, which is really unique because it's not using a closure device. It's basically another ligation technique, but in contrast to the lariat device. In this case, the ligation is made from inside. So we basically suck the appendage into the left atrium, and then we put around a suture which ligates the appendage. And I think this is really a very unique new technique where nothing is left behind beside this ligation here, and we do not have to get access to the pericardial space like with the lariat. So a couple of advantages compared to all the other technologies. We are also working on a new imaging tool, which is a little bit like the CAR2 system, what the EP colleagues are using, but this, in the current version, cannot be used for structural interventions. And we are working on imaging technique together with Shlomo Ben-Haim, working on this technique where we can do imaging for LAA closure without using echo and without using fluoro. And I think this is really may become a game changer in the way how we do structural interventions without fluoro and without TEE, and also without ice. So it's a completely new imaging technique. We wanted to do first in men a couple of weeks ago, and then this virus came across. So we have had to postpone this until summer or maybe autumn. We don't know yet. You all are aware about the major You all are aware about the major progress with TAVI. We started with these two valves, PVT and core valve. This is the current standard, SAPIEN 3 and Evolut R. And in this year, TAVI, we have more than 10 different valves which are available commercially. 15 other valves are in development. It's done percutaneously, 14 French, local anesthesia. Procedure time is less than 1 hour, and discharge on the next day is possible. There's also major progress with pulmonary valves. These are the currently available valves, the Melody and the SAPIEN XT. And the problem with these valves is that very often the valve is too small for the annulus of the majority, actually, of the patients. And this has been overcome now with the venous pulmonary valve, which is self-expanding and going up to a much larger diameter, so we can now treat almost all patients with this type of pulmonary valve replacement or implantation. Well, mitral valve repair and replacement, these are the different techniques, more than 30 over the last decade, have been developed to repair or to replace the mitral valve. You all are aware of the major progress with mitral clip, the new mitral clip NT and XT, larger clip arms, much better enhanced durability, and so many technical advantages. And you are all aware of the results of the COAPT trial, which showed that in functional MR, with this technique, the prognosis can be improved considerably. There's another technique for functional mitral regurgitation, which is a Carilion device, which is basically a coronary sinus technique. We go with the catheter into the coronary sinus. We deploy a distal anchor here. We pull the device back. We pull on the entire device. This reduces the diameter of the mitral annulus. And then finally, a proximal anchor is deployed at the orifice of the coronary sinus, and the device is then released, so the tension is kept. And this, again, reduces the diameter of the mitral annulus and works as an annuloplasty device. We have done, the advantages of this are it's less invasive than other mitral valve repair technique, less invasive than the mitral clip. It's much easier to perform. The leaflets are not touched at all. And it leaves all other options open. That means even if later on a mitral clip is necessary, or surgery is necessary, or mitral valve implantation is necessary, all this can be done without interference with a Carilion device because it's in the coronary sinus. We performed a sham-controlled, the only sham-controlled trial in this field, functional mitral valve regurgitation, and you can see this was the primary endpoint was reached, so this trial was positive, so the effect of this technique is proven now. And what we also saw is something which is very interesting, because only with this technique we saw a positive remodeling in the treatment arm. This could not be achieved in the COAPT trial, and also, of course, not in the mitral FR trial. So for some reason, we don't really understand that this also has prognostic implication regarding the LV size in these patients with severe heart failure. Transapical chorda implantation can be done with the neocord. This technique is around since a couple of years. You can see here an example where by increasing tension on the chorda, you can see that the MR is basically eliminated in this case here. We are now working on a transeptal technique where this can be done without transapical access by transeptal puncture. You can see here a drawing. This is an early animal experiment. So this is ongoing, and I think we can probably do first in man also this year. Mitral valve implantation, well, again, a huge field. 23 transcatheter mitral valves have been developed. Many of them are already in human. These 11 systems have been implanted in humans. So this field is another topic for an entire Congress and will really explode. Then the forgotten tricuspid valve, 14 transcatheter tricuspid repair and replacement techniques. This is the mitral clip in tricuspid position, so it works very well, at least in selected patients. This is reduction of the TR. This is before, this is 2 months after clip implantation. And this is another technique where we are involved, and this is a spiral which is inserted in the space below the tricuspid valve, and this brings the chordae together, and then tricuspid regurgitation is reduced, like in this case here. Finally, tricuspid valve implantation. This is the device we have implanted, the Navigate, but there are other devices which are now either already in humans or in preclinical trials. For example, this is the first, our first patient with the Navigate. This is before, this is after tricuspid valve implantation. And there are other valves like the Trisol valve, which has a very unique valve design, and this the delivery system with this will be down to 30 French, which will allow to insert this via the jugular vein. And there's also, this is in preclinical, and there's also development from Korea, the Lux valve, which is already implanted in humans. I think they have done now about 30 or 40 cases, and we hope that we can start, well, actually, hopefully this summer if the virus goes away fast enough. And so devices for heart failure is the last chapter of my talk here. And again, this is really an evolving field. We have therefore created an own conference just focusing on heart failure devices. And last year in December 2019, we had 70 different techniques operating in this field to treat heart failure by catheter-based techniques. This is one example, the reviving technique, where we are able to placate aneurysms of the left ventricle, basically by a hybrid approach from the transapical approach and transvenous approach, reducing the diameter and the size of the left ventricle. Then a new concept, I find this very interesting, papillary muscle approximation. The background of this is treating functional MR. And as you all know, the papillary muscles are displaced, the chordae are under tension, the annulus is dilated, the closing force on the leaflet is lower, and the leaflets by themselves are normal. And all these different mechanisms have been attacked by other techniques, but nobody attacked really the papillary muscle displacement. And this is what this technique does. It's basically a technique where we go into the apex close to the apex of the left ventricle, and then we tighten the papillary muscles together. This reduces the diameter of the left ventricle, and it also reduces functional mitral regurgitation. There has been a clinical proof of concept in the surgical field where they did a randomized trials a couple of years ago, and they showed a positive effect when you add this procedure to a surgical repair of the mitral valve. There have been significant improvement in all these parameters, and we are now involved in the catheter development of this catheter version of this technique, where we can in animals already do this procedure and bring the papillary muscles together and reduce the diameter of the left ventricle. Finally, diastolic heart failure, a very important topic. There's basically no real treatment available for this entity of heart failure. And we are working on intra-atrial shunts. It's a creation of a small ASD, basically to decompress the left atrium and the left ventricle. Different techniques have been developed. We are involved in this one here, where you put a device like a fenestrated ASD device into the interatrial septum. And we are also involved in techniques where these defects can be created without leaving a device behind, using this device here where radiofrequency can be applied. So we are creating a hole in the atrial septum, then we apply radiofrequency, and these holes tend to stay open long-term, and this decompresses the left atrium and the left ventricle. And there's also another approach where we create these defects by a cutting device. So we puncture the interatrial septum, we insert this device, then the cutting device is, this is a back holder, and then the cutting device is activated, and we are able to cut out a piece of tissue out of the interatrial septum. And this also creates holes which stay open long-term without leaving any device behind. So then treatment of hypertrophic cardiomyopathy, you all are aware that medical treatment is kind of gold standard. Surgical myopectomy is still performed in many centers. Alcohol septal ablation, I think, is now the preferred technique, but sometimes this cannot be used because there's no septal branch which can take the alcohol and the balloon, and therefore there's a new technique which has been developed in China. This is a transapical technique where under external ultrasound a needle is inserted into the interatrial septum under echo guidance, and then a radiofrequency is applied. You can see the technique, the needle is going into the septum, and then radiofrequency is applied, and this reduces the diameter of the interatrial septum. And the advantage compared to all other techniques like surgery as well as septal alcohol ablation is that this stays away from the His bundle system, so the incidence of AV block is, as far as we can say today, is lower than with the other treatment techniques. So I think this was no, there's one more. This is a patient with a thrombus formation in the right atrium, a big thrombus which is staying there despite long-term anticoagulation. And the question is what to do with this type of thrombus, and it can also be used in tumors. And we are using a cryoablation technique where we go in with a cryocatheter, and then we are able to extract these thrombus masses out of the heart without surgery. You can see some of these pieces which had been pulled out in this patient. So I think this was my last slide. Thank you very much again. Again, this all is just taking off right now, and we will see a really explosion in this field of structural intervention. Thank you very much for your attention.
Thank you very much, Dr. Horst. You are the pioneer in structural heart disease, and I mean, you are a teacher of teachers, and I believe the way you have described the future and what's going on, probably the interventional cardiologist would be the new age cardiac surgeons, and they would be having a full control of heart right from medical therapy to interventional therapy for coronary artery disease to electrical issues, and also heart failure and structural heart disease. So this is the new, robodocs, robocardiologists, which are in making now, and I believe you will keep a strong association of your meeting, the APVIC meeting, and keep blessing us with your and guiding us in future, and probably have trained many of the Indian cardiologists who have special interest in structural now, and that is the new wave of cardiology these days. We have some questions. Probably we'll take one or two questions because we have already exceeded time by 2 minutes. Any of the panelists, Dr. Sokan, Dr. Dhar, you would have a question?
Dr. Horst Sievert first.
Hello.
Hello, Dr. Horst Sievert. Can you hear me? I am Ashok Dhar.
I can hear you.
Yeah, we knew each other since your days when you were more busy with carotid artery intervention and stenting. And there in one of your sessions in Frankfurt, you performed 26 cases in 2 days. And that was fantastic. And from that, we learned a lot about the carotid artery intervention. Though it is not today's chapter what you were speaking, but what is the current state in your center or in Europe about carotid artery intervention? Is it still there or has it come down? Is it not anymore very popular? Would like to hear from you.
Yeah. Okay. That's a very good question. And we are also working in that field, still also scientifically. I think the overall number of carotid interventions has been stable over the last couple of years, which means the majority of cases are still sent to surgery. But now, as we have new techniques for carotid stenting, the results of carotid stenting are getting better and better. And we in our center already see a really significant increase in referrals. And the reason for that is that we are now using proximal protection in 99% of our cases. And this has really brought down the stroke rate to below 1%. And then we are also using these mesh stents, which are also adding to the safety of this procedure. And as you are aware, there are a couple of other techniques which are still emerging and under development. So all over, I think the carotid stenting market will grow again. I'm afraid that we will need additional randomized trials to really establish this, but it's on the way up. It's going up.
Thank you. Thank you very much.
Dr. Horst, thank you very much. I do remember doing cases with you and live cases both at Hyderabad, at TCP, and also in China. We have one more question, is the last question. There are many actually, but what is the role of device closure in sinus venosus ASD, and what are the long-term results and complications?
Well, it's early stage, so the total number of cases which have been done, I think worldwide, is around 30 or 40. It seems to be a very safe procedure, so we didn't see big complications here. We do not know about really long-term results because this has started just a couple of years ago.
Thank you very much, Dr. Sievert.